So anytime that you have a study that actually has a name, this one's serious. This study is a repeat of a previous study that was done in 1996 by Neil Jacobson. This study done in 2006 was actually the last study Neil Jacobson did before he died. He died in his late 50s, so it was a bit of a loss for a psychologist, and we few behavioralists. But what I'm going to be presenting today is this study was really a dramatic challenge against a lot of fundamental ideas of cognitive behavioral therapy and the usefulness of even attempting to channel or identify cognitive manifestations in clients that are suffering from depression. So if you notice, like, the authors on this research paper, these are the who's who in both the cognitive world and the behavioral world. We have Dobson, and we got Dunner, we have Holland. I mean, these guys, you can bet your bottom dollar every single day this study was going on, they were making nightly calls to Beck because they had a lot on the line. So what I'm going to be doing today is I'm going to be describing, number one, getting a sense of what came out of this study, behavioral activation, which seems to be one of the best treatments for depression. So we'll be going through the pieces of what behavioral activation entail, what you need to do. And in general, I'll try and keep an eye out for just more practical clinical use of this approach as I go through this actual research paper. I really regret I didn't send you guys the actual paper. So if you're totally interested, type in Google Scholar, the title, Randomized Trial of Behavioral Activation, 2006. You'll get the paper. Okay, so the abstract. So this is the abstract of the study. So what they did here was like I said, we're having a replicated study from the one in 1996, and we're pitting against medication, the full cognitive behavioral therapy treatment, and behavioral activation. And there was really two main motivators for why they were investigating this. Well, number one, as far as medication goes, it is, according to the APA, the current standard as far as treating depression. But there's a lot of questions in terms of clinical use of medication. Number one, it might actually mostly be a placebo. There's a lot of really good research out there that's indicating that 80% of the effect of antidepressants is actually placebo. So if you're, say, using the Hamilton scale...
I thought it was 60.
80. So if you're using the Hamilton scale, you're probably getting an improvement of 2 points on that scale. That means it's not even clinically useful to give people medication outside the placebo. That isn't to say medication isn't useful, because placebo is very powerful. I mean, if we're going to be fair, most of therapy, the work that we do with people, can easily be argued to be under the category of the placebo effect. It's a social relationship with another person. So medication is quite effective. And how to actually try and get the placebo effect without letting anybody know, giving them a sugar pill. We have ethical questions of whether or not we can actually sell sugar to people. So that's one problem with this thing. But a lot of times people don't like being on medication because, quite frankly, it's painful. There's a lot of side effects. And just getting on the medication, in best case scenario, you're waiting out a month of turning your life upside down, and maybe the medication is going to balance out after that month. So while medication is the advised primary initial treatment for depression, a lot of problems with it. As far as CBT is concerned, which is the gold standard of therapy for depression. I mean, depression was Beck's golden boy, so to speak, when he wrote his first book coming out against the psychodynamic approach. Before CBT, we were seeing with a psychodynamic treatment something like 2% of clients actually recovering from depression using the psychodynamic approach at that time. With Beck's approach, they were seeing dramatic improvements in terms of recovery. But despite that, there's a lot of different outcomes in the research showing, well, maybe it's not as effective as Beck was using it in his line of work. If you ever see videos of Beck doing what he does, I mean, the man is beautiful. It's like watching poetry, watching this guy work. You'd never suspect the man who crafted one of the most systematized, orderly treatments is this poet in front of you. So there's definitely this element of common factors of the therapeutic relationship that would probably go a fair way in describing why sometimes CBT is, in research, looks pretty good when it comes to depression, and why other times it doesn't really look so good at all. Another part of why pushing this particular research paper forward was this idea that Jacobson had stumbled upon himself in '96 when he was doing his original component analysis of CBT, where it was coming out you really didn't need the cognitive aspects of CBT to get great results. So I want to get into that a little bit more. So, spoiler alert, what were the outcomes? It turned out that behavioral activation was way more effective in treating severe depression than medication. It was way more effective in severe depression than cognitive behavioral therapy. And it had a great job, even though you might not get most of your clients passing that threshold to no longer being clinically depressed. It had a giant response rate. So even though you weren't actually hitting your therapeutic goals, you were getting somewhere, which that was definitely lacking in the other two options with the medication and CBT. So the '96 study. What Jacobson was going into when he was doing the study, he wasn't expecting actually to find dramatic differences. He wasn't expecting to find the cognitive part of CBT to not be important. When he was pulling apart all the different aspects of CBT, he was expecting to find that basically what everyone else's assumption was that would probably be the most important aspect of the treatment. So what he did, he was able to get 150 participants in his research program, and he had the same group of therapists treating everybody with only the behavioral aspects of CBT. So it's not a full behavioral approach. It's just things like activity schedules, mastery pleasure ratings, graded task assignments, just bare bones behavioralist stuff. And that would be group one. And the same therapists were then tacking on targeting automatic thoughts. Now we're getting more cognitive. And then the third final group was the full form CBT. The results were shocking. There was literally no difference between group 1, 2, or 3. They all had the same level of recovery, and they had fair ratings across the board. And it was great that it was the same group of therapists, because he was almost like within the research factoring in those common features of the therapeutic relationship. The same personalities are doing the three renditions of the treatment. So what he got out of this was the thought, well, if behavioral activation, the behavioral aspects of things, had one hand tied behind his back, wouldn't it be interesting to see a full, pure behavioral approach to depression? What would that look like? And the second was that this '96 study was dramatically challenging the idea that you have to go deep when treating depression. And it might actually be a better idea to grab the low-hanging fruit. One of the first rules in CBT anyway, the first several sessions when you're with a client, you're actually only targeting those low-level fruits, because from a cognitive perspective, you're trying to get rid of the cognitive distortion that therapy doesn't work. So you actually try and get a lot of really quick gains in the beginning of therapy, and then you move on to really trying to hit hard automatic thoughts and core beliefs. So, well, what if you don't even have to do that? What if you just keep it simple? Go for the low-hanging fruit. Okay. So the behavioral components of this, as far as, like I mentioned in this study, it was activity scheduling, where basically, one before. Yeah. So the three behavioral techniques that were used in the '96 study, like I said, was just activity scheduling, where basically what you're doing is you're monitoring the activity of a person over the week and putting it into a grid. And what you're doing is you're putting labels of, well, how much pleasure or how effective, how much mastery does the person have when he does the things he's doing in his life? And then we'll taking a look at his life in this sort of very bland, straightforward way, then raising the question, okay, well, whatever challenges you're facing in your life, let's break down those bigger, more complex problems and take baby steps and see if we can't clean up your activity schedule and make life easier for you. As far as the cognitive aspect, in group 2 and 3, this is a nice list of all the cognitive distortions that they were more or less trying to address. And I would say, as far as giving how you kind of like summarize a cognitive distortion, I think a useful way of thinking about them is an overly rigid map to life. And that even though this overly rigid map of life is low resolution and has poor depth, it actually has tremendous scope in being easily applied to how you interpret everything in your life. So there's I'm getting behavioral minded here, looking at the function of these sorts of things, but the function, I think, in large part, is having, say, black and white thinking reduces how complex you have to be when you look at the world. In every sort of situation, black and white thinking can be a very good, bad way of understanding your life. It's a very good, bad way of understanding your life, meaning it's effective. You can explain life with some level of satisfaction, but it lacks such depth.
I would say security, not satisfaction, but a level of, I think black and white
Could
thinking gives people security because they don't want to be in.
Could be.
Right. It's.
Could be. Looking at the cognitive model, what you're ultimately trying to do throughout treatment is slowly identify. You're keeping a list of automatic thoughts as you're going through treatment, and using different restructuring interventions, say like the Socratic method, or a really good one is the downward arrow intervention. What you're doing is you're really trying to get a clear picture of, well, not just what these automatic thoughts ultimately are, but what are the schemas, the core beliefs that underlie every core thought. So you can use something like the downward arrow intervention, not just as a standalone sort of intervention when you're dealing with a nasty automatic thought, but you use it as a diagnostic tool to figure out what are the schemas that are probably lurking underneath.
You said that was basically downward arrow?
Well, basically what you're doing is, someone has a problem, they're worried to go out in public. Okay, well, why are you worried out to go out in public? Well, maybe someone will see me. Oh, okay, that's interesting. Who do you think will see you? And what you gain basically what you're doing is you're taking this low resolution cognitive distortion, giving it depth, giving it detail to the point where you're really arriving at something you can start challenging effectively. I find people terrifying. That would be maybe a common schema a person would have. And you can, once you kind of arrive at that core belief, you can start challenging it in different ways, in different contexts. So that's how you would use it as a diagnostic tool. Okay. Yeah. And one I love is as far as the cognitive stuff goes, is the emotional role play, where you, the therapist, would take the role of the nasty thoughts, the core belief, and argue with the client. And then you switch roles and have the client take on the core belief and argue. And there again, this sort of cognitive restructuring is flushing out how this is such a low resolution way of looking at life. It just doesn't really work so well. And man, if you just add some detail, the problem shrinks, becomes something you can solve, and maybe you don't even have to solve it. Maybe it's so small with all the detail that you add, it can actually just hang out and be there. It's not such an issue. So that was the 96 paper. Those were the different interventions being used. And with this 2006 paper, the gloves are coming off. We're untying the other hand of the behavioralist to see our...
2010.
This book is 2010. This is an outline of behavioral activation. So if you guys want to read a good book on behavioral activation, this is the book you want to get. These authors were a part of the study I'm presenting, and a lot of what they came out with in their 2010 book is exactly coming from that research that we're covering today. So there are 10 core principles to behavioral activation. The first is the idea that the key to change has nothing to do necessarily with trying to target how people think or feel, If you want to change those things, if you want to improve someone's mood, all you have to do is just change what they do. That's principle number 1.
That's complete behavior. That's just
Complete 100% behavioral. Nothing else. The theory of how depression comes about with this approach is, obviously, life's tough, life knocks people around, and it's normal for people to feel depressed when things don't go their way. But what ends up happening with depression, as opposed to being really upset because something bad happened, is when you are, say, from an emotional theory, sadness has a function of making a person stop to take stock of their world. That's the function of sad. That's why you don't want to do so much stuff. That's why you stop dead in your tracks. Something's not working in life, so it's probably a bad idea to keep pushing forward. It's a good idea to stop and take an accounting of what's going on. But what that might actually do is start disconnecting a person from how life in other different aspects of life feels really good. And the depression builds, and it becomes this positive feedback loop to the point where you ain't getting out of bed. The third principle to behavioral activation is that what you're really trying to do is you're trying to find what are the depressing behaviors that is in the person's life, and what you're wanting to do is replace them with antidepressant behaviors. So what you're doing a lot of is you're tracking antecedents and consequences that are surrounding the behavior of depression, and trying to clean those up. You're going to be creating a structure and scheduled activities in the person's day. And the basic idea with this fourth principle is that the action has to follow first. You don't wait to be in the mood to do something. So there's a nice little thing I like to do with clients. I have the benefit of having a sink in that room, and I love it because I get to do this intervention with people. Someone's coming in to kind of describe this idea that don't wait to feel like you want to do something. I have my dirty cup of coffee sitting next to me. I say, okay, pull open the screen. We got the sink there, and I ask, on a scale of 1 to 10, how much do you want to clean my cup of coffee? Now they're saying 1s, 0s, -5s. No one wants to clean my cup of coffee. So fine. So we're just standing there. And I asked the person, okay, well, you know what? What's that over there? Oh, yeah, that's the sponge. Okay, and where's the soap? And they find the soap. And what does the soap smell like? Oh, they smell this. Oh, it's apple. That's great. And okay, go ahead and pick up my cup. And they pick up the cup, and I go ahead and pick up the sponge, and they pick up the sponge. And then I say, okay, go ahead and sit down. And they all look at me like I'm daft, like I'm ready to clean it. And when I ask them on a scale of 1 to 10, how much do you want to clean my cup of coffee? It's usually 7s, 6s, 10s. The mood doesn't come first. What you have to do, and this is kind of, point 5 here, that change is easier when you're starting small, is you're building a chain of behaviors that are approaching ever so slightly to your target. And that's the only way change is going to come. That's the only way you're going to be in the mood to do something. Is you have to act first. Number 6 is you're looking for, as you're restructuring a person's life and you're finding antidepressant behaviors, you're looking for things that are naturally rewarding. This one can be pretty tough because, like I said, the person really doesn't want to do much of anything. So you're not, in as far as gauging your success going through behavioral activation, you're not waiting to hear how great things are. You want to hear, oh, that felt weird. You want to hear, oh, that felt kind of awkward. That's fine. Just as long as the person doesn't say they were suffering while they were doing it. And gradually, as you go through the entire therapeutic process, those, hey, that's awkward, hey, that was kind of weirds, that was okay. Oh, I'm kind of enjoying that now. Hey, that feels great, is going to develop.
Can I share?
Yeah.
I have a client who's depressed, can't get out of her behavior, keeps wanting to change her life. And so she started to talk, and I listened to her. And she said, then I'd have to go get new clothes. I'm like, good, I want you to go to the store, get an outfit.
Yeah.
She's like, what? That'd be expensive. I said, no, you can find something on sale today. Clothes aren't as expensive, but can you imagine?
Yeah.
What would it be like just to go in the street? She goes, well, I'm a little heavy. I said, yeah, but they have nice clothes for women of all sizes. You can go in, find yourself. And what will it look like? And what color would you like to get? Mm-hmm. And when you get this, I just want you to hang it in your closet and look at it. And this is my going to work outfit. She wants to shop.
Yeah.
That's all she's doing.
Yeah.
Because if I just told her to get a job, nothing's
Yeah, nothing's happening.
And the reason, and then I said, if you want, you can pay me. I'll even come with you. I've done that. I have actually done that.
Yeah.
We'll go to the store and pick out something that you feel good about.
Shopping
Some
day.
women, they need that.
Will you do that with me?
You have to pay me. And it was just this idea of you can't get to her. She keeps wanting, everyone tells her to do, and I'm like, okay, well, what do we need to do first?
Yeah.
Well, if you had an outfit, you might feel a little bit more confident. So what's that gonna, and that's very important. And what about, and she says, well, I need shoes. I said, well, it's, fine pair, everything can be on sale. How much, just go and let's just imagine. She was getting all happy about this. But that's it.
Yeah. What's cool about your example is it went from being an artificial reinforcer to a natural one when you linked it to work.
Yes,
And now sometimes you want to have an artificial reinforcer. So, I had a client who, the guy wasn't showing up to yeshiva, again, dealing with self-esteem issues. There was a bit of depression, a bit of anxiety. And so he was irritating his Rebbe something fierce to the point where he was being threatened, man, if you don't show up to class, we're kicking you out of yeshiva. So, although you want to strive to find natural reinforcers that naturally exist in a normal person's life, well, sometimes you have to, do a kickstart, like, buy an outfit, that'll feel good. Mm-hmm. Here I said, if you were able for a week straight to, I had to make a chart, and we were putting stickers every day when he would show up on time, and we built, up behaviors where what he would have to do in order to show up on time. And I said, man, if you're able to bring in your chart with all your stickers, I'm giving you a Snickers bar. The guy did not get kicked out of yeshiva. It's not the best intervention because it's not a natural reinforcer, but at the very least, I was fending off falling into a deeper depression because now he's disconnected from his friends and something that gives his life meaning. Number 7, act as a coach. Person's coming in, you're just pushing them forward, you're giving them encouragement, trying to be the fuel to let's do something next, do something else, do something else. Which is really 8 and 9 of emphasizing problem solving. We're testing out, well, let's just see what it feels like to put on that dress. Let's just see what it feels like to put on those shoes. And like I said, the bare minimum is if they don't feel like it's suffering, god-awful, you've hit your target. Mm-hmm. That's the bottom line. And, like I said, just doing it, number 9. Yeah, go for it. What's up?
So psychodrama, what I like about it is that we try really hard not to sit in the chair for more than like 2 minutes.
Right.
And like we're doing life. We're doing like I call it rehearsals for life. Like, okay, what does it look like in your kitchen? Let's do your kitchen. You can't handle your kitchen. Okay, let's redo this scene. Add something else. Add breathing. Add this, and then we redo the scene. Yeah. With some new element in it. And I'm not as good as walking outside as you, but at least we don't sit in a chair, which is why I like a big room.
Yeah.
Well, I think that idea of getting out of there, it's also the act idea, get out of your mind into your life. Like you are not getting stuck in your thoughts, which narrow your life. Yeah. Which is a very, and it's very, very helpful because how much is talking going to help them? They're just...
Right.
It just kind of like they'll just get in. I told them you're just getting deeper into your depression. You just doesn't work until we can get you to do something. 100%. So I'll tell people you have 5 minutes to kvetch, then we're doing something.
Then we're doing something, right.
Because they need a place to kvetch.
Right, 100%. 100%.
They don't always have another place.
100%.
But not for 60 minutes.
100%.
After a while, you hear it just is helpful to them.
So what if like the thought, like the negative thoughts, like that are keeping them depressed, are intrusive, like they can't stop?
We're going to get to that because behavioral activation does have specific interventions for rumination, which rumination is just basically avoidance also.
Well.
So we're gonna, we're gonna hold that one. And then the last core principle is, troubleshooting, which your goal is not just in the moment troubleshooting what might happen or what might get in the way of the homework or whatever exercise you guys agree on. But this in of itself is its own intervention. You want to train someone to be really good at troubleshooting because we don't want them to be hanging out, for who knows how long in therapy. They need to be their own therapist. And it's the troubleshooting aspect here that they need to take home and really get a sense, okay, I can do this one. Yeah. And it's simplistic enough they can do it. That's also another idea here with any time you're not just with behavioral activation, but any treatment you're doing, kind of having an idea in the back of your mind of, okay, fine, whatever I'm doing, try and simplify it as much as possible because I want this person to repeat everything we're doing here in the rest of their life so I don't have to see them again.
It's true.
Okay, so I just want to cover briefly, what the difference is between consequences and antecedents, and what these things really involve. So when it comes to a consequence, a behavior, when you look at a behavior, it really has three parts. It's, what comes before the behavior itself, and the consequence. So an operant is really a behavior that's controlled by a consequence. It has a function. So kind of what you're talking about, looking at safety seeking. Well, that's an operant. Its function, whatever that behavior is, its function is being safe, or maybe it's getting attention, or maybe that's how you get assistance. Maybe that's how you get approval from other people. I had a client who he came in, and his a lot of different issues going on, but one big one was he was randomly throwing up in public.
Oh,
Just randomly.
It was specifically in places, as I was going through a functional analysis, it came out, it was in places where he got a lot of approval and a lot of support from people.
A lot of sympathy.
And it was a lot of sympathy. It was interesting because what caught my eye about this was he kept going back to those places. He didn't have a phobia of, let's say, going to shul is a good example. He didn't have a phobia of going to shul. He didn't have a phobia of being in the shots. But man, every time he did it, off to the bathroom or right there on the floor. So looking at that behavior functionally, well, okay, it's getting support, it's getting praise. Let's get rid of that as soon as possible. So we agreed, okay, what we're going to do is, go into shul tomorrow and talk to everybody in shul and just let them know, okay, guys, I'm trying something weird here. If I throw up, I don't want anyone to say a word. You just leave me to my own devices. He stopped throwing up within a couple days.
What did he use to get that attention? He needed it.
He threw up.
No, but now he's not throwing up. So now
yeah,
what's
where's
he
he
going
gonna
to
get
do?
his love and support?
Now what's he going to do to get that same attention?
It wasn't lacking in other areas.
So
He had
what did he need in shul?
went away and he felt great.
And that was just
Well,
That's it.
Again, I
Didn't-
think what everybody's asking
Didn't
is,
care because it wasn't a problem.
didn't have to show up. No, but
He still got the chance to be shots. And I wonder also, when people finish, they get the shkoyach, he got the chance to get that shkoyach he never got, because he didn't have a chance to finish davening, so that was great.
But that was what you used to fill that.
That was it.
Because he needed something.
That was it. What were you going to say?
no, I mean, I'm kind of like going on Lena's direction is that obviously there was something that was filling in, so when he stopped, meaning he was getting something out of it. So the question is, what did he replace?
Those are two very different statements. Filling in or getting something out of. It might not be that it's filling anything. He might just be getting something out of it. That's a very different way of looking at the problem.
Right, he's getting something out of it, but
Yeah.
the question is, once he stops,
What's
what does he fill in with?
Right, that was
meaning
my-
It might not be that there's any necessity to think about that. That's what I'm arguing from a behavioral standpoint. And I'm saying in theory it could be, if that was a problem, well, maybe that was resolved and I never had to discover it because he was getting the shkoyach when he finished davening. It could be.
Okay, well, that's a shkoyach
but
when he finished davening, but the fact-
But I wouldn't necessarily assume you have to fill in anything. It just could be the cycle got out of control, and maybe there was one moment he had food poisoning, went to shul, threw up, had a great experience. Everybody being very supportive, and maybe that was in connection with the touch of anxiety he had already. That it had a physiological effect, and the thing just went on a like I said, a positive feedback loop. Could be.
Sometimes it's like she did that too. Like,
So the operant has a function, and it's getting something, and it's either the function is going to be some sort of reinforcer, positive or negative. Positive reinforcer, getting a lot of attention. A negative reinforcer is, classic example of that is the phone. The darn thing won't stop ringing, and then you answer it. It stops annoying you. That's a positive. That's negative reinforcement. Or there's a punisher that will decree that you're looking at the consequence, and that's a punisher or extinction is how you decrease specific behaviors. The other side of this, the antecedent, well, that's really responding conditioning. That's classical Pavlovian sort of stuff. That's what an antecedent basically is. a lot of people kind of look at this as like, oh, it's a reflex, and not quite. I think that Riscorlo had a really great way of summing up what respondent conditioning is. That it's not a stupid process by which the organism willy-nilly forms associations between any two stimuli that happen to co-occur. It involves the learning of relations amongst events, so as to allow the organism to represent its environment. What antecedents, what classical conditioning really is the creation, or really more the revealing to the organism of the value it sees in its environment. It's very meaning value based respondent conditioning. So in order to change an antecedent, well, what you're trying to do is you're trying to break this association. You're trying to cease making that antecedent have the value and meaning it has. So in a situation of depression, well, feeling sad, you want to cut that guy off from not doing anything. Okay. And as far as like the way these two things kind of go together, looking at Watson and Tharp, I love that this is a really good way of summarizing operant conditioning as relationship to respondent conditioning. And it's through operant behaviors that we act, we function, and produce effects on ourselves and on our environment. And that through the effects, through those consequences, the environment acts once again on us, becoming an antecedent. So in as far as what you define as a consequence or what you define as an antecedent is fairly subjective, because it really is a loop of continual motion, continual movement, action unfolding. As far as the stance, the overall philosophy of this model is we are trying to maintain as a strong emphasis the session structure. Action-oriented, you're validating constantly, but you're doing so strategically, where either you're trying to regulate the mood of your client, you want to try and bring down their emotional dysregulation so you can do planning work with them in their life. It's not to make them feel good, although that might be nice, but it's in order so that you can actually do work with the client. Or number two, you're using validation as positive reinforcement. You're trying to increase specific behaviors you want in session. Either you see some sort of adaptive behavior, it's bam, you jump on that one. Or the person sharing information. It's going to probably be very painful information. They won't want to share it. So you have to validate and positively reinforce that sharing so they do more of it. So you have more data as a clinician to solve the problems that are affecting this person's life. And also, you're kind of looking out for anti-avoidance in general, which is kind of similar to the other point I mentioned about just sharing the problems they're having. So that's validation. Working collaboratively with the client, you guys are two people together. There's less of an emphasis on you being the expert, although you are, and that's recognized. But you're really trying to tone down that one, and it's this sort of curious, open sort of, hey, let's just see what happens if we do this sort of relationship, as opposed to instructing and being more dictatorial about it, I guess is one way of thinking about it. And so you're being non-judgmental, expressing warmth, having genuine regard for the client, and you're trying to reinforce all these reports of when they're doing well, when they're being adaptive in their life. And as far as the specific acts that you're doing as the therapist, you're really cycling through 8, where you're constantly trying to assess the factors that are contributing to the depression, and you're trying to counter the avoidance. That's what the big emphasis in behavioral activation is. You're framing everything as just an avoidance behavior.
What do you tell the client?
Basically this.
You tell them they're just doing that to avoid it?
Give a basic explanation of behavioral jargon, more or less.
But they're trying to avoid it, why?
So we work that out with the functional analysis. You usually never have to actually answer that question because you're starting with the functional analysis, and it's like, oh, okay, that's interesting. So, you yell when you talk to your parents. Okay, fine, that's interesting. Oh, when you go to work, you yell at your boss. Oh, that's interesting. Oh, so you just notice, it's the same problem manifesting over and over and over. And you kind of beg the question, well, how's that working out for you? Not really well, and that's when you kind of jump into making the distinction between good short-term solutions and bad short-term solutions, and how maybe you want to try and and what we'll work together building is better long-term solutions. That's really that's the basic bolts of how you kind of describe that, and it seems to work.
This is used for depression.
Yeah, you use this in any other context, not just depression. I mean, this is a good formula for anxiety. It's a good formula for as far as my work in personality disorders with borderline personality disorder works just fine. In fact, oftentimes the less complicated, the better. And that's the beauty of this approach is it's just so simplistic. You don't really need so much explanation of how this stuff works to get the person on board.
Well, I would imagine it depends on the individual.
Mm-hmm.
Like some
Yeah.
people are more curious. And
Yeah.
people are less.
Right,
Yeah.
yeah, well, I mean, if people want to understand where this comes from.
Yeah. Okay. And so again, again, you're always cycling through trying to be as specific as possible. You're monitoring every behavior, trying to get to the nuts and bolts of exactly what was happening, when, where, and how. Constantly validating and just assigning activities, troubleshooting, and encouraging. That's the whole session is going to be these 8 over and over and over. Okay. So the treatment stages unfold, and I kind of already got into this, I guess, is you're starting with a functional analysis. You're linking all your A's, B's, and C's, your antecedents, behaviors, and consequences together to get a picture of what's going on in the person's life.
Oh.
Well, that's avoidance, yeah. That is avoidance.
That's so funny. You're saying patient.
Painful.
Yeah, very painful, yeah. Yeah.
Relaxing. To put your head in the ice.
Oh,
Oh, tomorrow.
I know.
You need to go on vacation.
Yeah.
Ice fishing.
Ice fishing, right.
Ice fishing, it's perfect for you.
You know, I have a really fun mental picture of that right now.
Maybe he's looking for tips. Maybe he's
hiding from his problems. So like I said, you're basically through the functional analysis, figuring out what behaviors are causing the depression, and you're setting up an activity schedule to replace those things. You know, you're monitoring the behavior, you're doing the problem solving, and that's really the activity schedule is the core of the work you're doing. You know, you're making sure the guy's bringing in a sheet every week, and that might be a problem, so you're going to have to try and use some tactics to make sure and encourage and increase that behavior of bringing in the sheet every week. But like that sheet is the nuts and bolts of this thing. And ultimately what you're doing is like I said, the behavioral activation is more or less looking for and defining maladaptive behavior as always being avoidant. So there's never really a big surprise what the problem's suffering from. You're just basically calling it avoidance and fishing out how this is avoidant and replacing that behavior.
Can I just ask, like,
Yeah.
if that behaviour involves, like, going to the shops, and yet in the shops is where you have your triggers, because of the culture in Israel,
Yeah.
where it puts you back into your depressive, like, people can't, there's no customer service, they don't care, no one cares, like, they're rude, like,
Yep.
it's great. So, but you want them to go out of the house,
Mhm.
'cause- but then they get a
Right, yeah.
reinforcement. I'm just
Yeah,
thinking,
yeah.
how do we-
They get what they want to buy.
Pardon?
They get what they want to buy. Yeah, that's what they hear. That's
Well, not if it falls apart and then they don't get the customers, you know.
No, right, yeah. I mean, the way you...
That's
Right.
depending on somebody else doing something for you.
What that would basically look like is you're using the activity
It's
schedule
not exactly
I'm
what.
just, sorry.
in such a way where you're breaking down the behavior of going to the shop into small parts,
Yes.
and it would look very much like exposure therapy, graduated exposure
Right.
therapy. That's really what it is.
Go
Exposure
out of your
to-
house.
To the painfulness of going to the store. And seeing that you can survive it, and you're wanting to, as far as like the behavioral aspects concerned, you know, putting in, you know, value of what this will mean for you as this is changing your life, and good job, you were able to take those 10 steps towards the store, and now you did 20, now you're in the store.
That was like, I mean, it's patronising for someone that knows how to shop, they just don't like people that are, like, don't take responsibility for an item.
There's an interpersonal finesse you have to do, but that's basically the structure. Exposure therapy.
Well, you may also need to start with a store that they actually like, and once they get over that for a while, they might want to move on.
Okay. So we're really, as far as our primary target, we're looking towards trying to reduce avoidance, and we're also trying to the way that behavioral activation looks at rumination is a lot different than cognitive therapy, and we're going to get into that. But you're targeting rumination, that you're highlighting the consequences of the rumination. You're highlighting the consequences of rumination. Well, what does rumination get you? A whole lot of pain. And you're trying to figure out different activities to replace rumination with. Maybe one way to problem solve this one is set aside 10 minutes of rumination and leave it at that. You might be able to get away with that. You're using mindfulness skills to try and, I was saying earlier, rumination is in and of itself an avoidance tactic, where what you end up doing, you kind of imagine like an upside down cone. Like rumination is the point of the cone, and up here is all the detail and all the real meat of what's going on in that moment. And what you're trying to do with rumination is you're trying to get the person to move from that low resolution, my mom's coming to visit, my mom's coming to visit, my mom's coming to visit, to increasing more detail. And the broader of a description you have of that moment, it's almost like, well, you're experiencing more, you're seeing more, and solutions almost feel like they present themselves to you as opposed to having to come up with them. But it's the more contact you're willing to have with that thought, the more possibilities are going to manifest themselves. So, and maybe you might also have to use a little bit of distraction or, some other sort of things to get by. I wouldn't exactly encourage overly using distraction because you get the boomerang effect on that one. But if it's a question between something really bad happening and, okay, well, maybe we're running a risk of this being a crutch, maybe it's a good temporary crutch to use distraction.
So, any information on this with kids? Because I have a couple of ruminating kids.
Yep, works great with kids.
Do they
In fact, it's easier with kids because kids are generally more curious. And there's more.
They'll follow your what would happen.
Yeah, and there's a lot more flexibility in the way that they and a lot more authority they're giving you also. So it's like with kids,
not necessarily all.
more than adults, that's for sure. So it's you have those two pluses on your side. So generally, kids go along with this a lot more easily than adults. Although this is pretty straightforward for adults also.
4-year-old, 5-year-old stuck on.
Yeah, sure. Yeah, in fact, their entire school systems that use mindfulness start their day. They have like 20-minute mindfulness in the morning, and that's the way that they solve their inner city crime problem in their school. And they're using it from kindergarten, up to high school. So what are the differences between behavioral activation and cognitive therapy? So like I said, the main target for behavioral activation is avoidance. You're trying to increase the opportunity for natural motivation. You don't want to just keep giving this person dresses in a candy bar, but it has to be rooted in their natural environment. And while both approaches have experimentation as a part of the treatment, they're looking at experimentation very differently because, well, for a behavioralist, hey, let's try this experiment to see what the consequence is. There's no tricks involved. Does this feel good? Great, it feels good, do it again. Whereas from a cognitive standpoint, experiments are not so much to get the person to do something, but it's to prove, hey, see what happens when you challenge that cognitive distortion. It's more cognitively based. And again, when approaching rumination, from a behavioral approach, you're looking at thoughts as useful or not useful, not true or not true, truthful or not truthful. That's more of a cognitive way of looking at thoughts. And your focus is on, well, what's the functional process? What do these thoughts get you? Because they're getting you something. And again, like the process, there's very...
That's not true for OCD comes with the person really not feeling they have any control over it. The brain is it's different in a sense.
This theory, the way of defining rumination, even for OCD, works. You can frame it that way, and it's really cool. You can do it. Again, when comparing these sort of approaches is not to say one is correct and one's not. because you definitely can treat OCD not this way.
I still find exposure therapy really good for OCD.
Yes, yes, you do. A part of that can either because you're challenging the thought, or you're seeing the thought's not useful. Like the structure of what you're doing is up for debate. You might end up from like I said, both the cognitive approach and the behavioral approach are both using experimentation, but there's very different reasons why you're using it, and so it'll come up in treatment differently. But maybe it doesn't matter. Maybe all you just need to do is the point is the experiment, and not so much why you're doing it. So I'm not trying to, even though there were great results with behavioral activation for depression, I'm not trying to say one is a better, more truthful treatment than the other.
I think that it's really it's a combination of both. I mean, I find like some clients react better to some therapies, and other clients react better to other ones. And sometimes it's a combination of really doing some cognitive, some behavioral, and whatever speaks out to them. I mean, I think what happens is you get, if the only thing you have in your toolbox is a hammer, everything looks like a nail. So you gotta kind of like work around and see some clients, because of their background, let's say from family of origin, need a little more coaching, need a little more behavioral stuff. If their family system is good, then they may need a little bit more cognitive stuff, because it's what we're both.
Really, the clinical outcome of this is, well, we're kind of seeing, I gave the spoiler alert that behavioral activation does have more success. So it's like, that might be true, but don't start there. It might be clinically more useful to always start with the position of, I don't have to deal with thoughts, I don't have to deal with core beliefs. Maybe if I just get the person to act differently, this one's going to go away. And it's highly likely that's true. And there is a trade-off that it might actually be, until you have some indication maybe more of a cognitive approach would be useful, it might actually hinder treatment. So it's never immediately obvious which way to go to begin with, but if you're playing safe, what this research paper and all the work that's come out of behavioral activation would indicate is it's probably the best place to start, all things considered.
For depression.
Agreed.
Because I think that a lot of depression goes around thinking patterns, and so to break the thinking pattern, to try and break thinking patterns with other thinking patterns, it's kind of like trying to get yourself out of a problem using the same logic.
It's very cognitive of you.
Right.
Yes.
The fact is getting people up and moving, but sometimes it's a really hard thing when a person can't get up and moving.
Yeah.
If there's no chemical imbalance.
Right.
No,
I mean,
Do you know that chemical imbalances are really up in the research in terms of whether they really exist?
Right. That was the 80% placebo effect.
It's a question of how much it really exists. They actually haven't been able to prove it as
in depression.
And even more so, getting cognitive. What you can end up getting snagged on is the question, answering the question why. Within a behavioral activation approach, you're not asking why ever. You're staying away from why like the plague. Because when you ask why, what ends up happening is you might actually be stumbling on the client giving you a socially understandable, acceptable rationale for the behavior, having nothing to do with why they're actually doing it, just so they don't look stupid. And it reinforces and it ingrains more vigorously the behaviors that are causing the problems. Now, what I thought was really interesting, I was thinking about this because if you look at the research on bibliotherapy, amazing. Bibliotherapy is an awesome approach of getting people to write out their problems, but why doesn't hack it when it comes to bibliotherapy? What you're shooting for when you're doing that sort of work is you're wanting to encourage the client to have, in his writing where he's describing what he understood, what was revealed to him, what he realized, what he saw, but not why. Those are very different descriptions of their life. And so it reminded me very much of the way Freud defined catharsis as being the linking between thought and feeling. A lot of people kind of think of it as catharsis as getting out an action. It's totally not what he was talking about. But it's really linking feelings and thoughts together and giving them more of a phenomenological lived experience so that they can be something you hold. Very much like that. But whys are the worst, even in bibliotherapy.
I think another thought is that something like internal family systems
when you do identify, besides behaviors and cognitions, emotions,
Yeah.
and you bring a connection there and a validation of it and respecting of it, that seems like an approach I didn't hear from you that could be also very healing and very healthy, as to we wouldn't avoid at all costs the why. We would allow the
Right,
person to
IFS is
actually,
very different that way.
we would
Yeah,
approach
that's
that
you're right.
approach
Right.
Which is also
That would be a
useful.
difference. That would be a huge difference. Right. Yeah, behavioral activation is banking on the assumption why is dangerous, whereas other therapies not. Other therapies wouldn't. But I thought bibliotherapy was a good example because that's like that one in the extreme is trying to find more explanatory aspects to a person's life, but what's missing even there's the why. Again, it's more of the realization, the noticing, the understandingness, which is different than why. That's kind of what I wanted to suggest, as one way of splicing that one.
Bibliotherapy totally depends on where the person is going with it. Some people will write the story of the why of the kid who went through ABC, or the father or the mother, but other people will write...
And is not as effective. That's what, and is not effective. That actually makes a difference. If the
Depends what the kid wants to write.
yes, but if you're a betting man, you're hoping he doesn't write that. Now, it might work out, but if you're a betting man, you don't want the person to write whys, because they actually don't work as well.
Depends what your goal is. It depends where you're going. Maybe it'll help a person to learn that they can handle
It could.
behavior.
It could. But again, like it's
What's the long-term outcomes of this behavioral activation and CBT versus the more deeper concepts where we're digging in the whys? Like, I hear you 100% that
Yeah.
within the first year after whatever it will be better if you just help them think about it differently, help them do
Yep.
different at that moment. My question is, 5 years down the line, 10 years down the line, are they back in the chair?
nope.
What are the follow-up studies
Dobson
like?
after the study did a long-term follow-up of after 2 years, and the outcomes were solid. Outcomes were solid.
Years after the 2006
2 years after, yeah,
or
2 years after treatment, these folks were solid. So we're kind of dancing around this idea that that they are very these two ways of approaching a client. Whether it's with whys or whether it's more behavioral, we're looking at two very different things. Behavioral activation is functional. We're looking for trying to examine behaviors only through that lens. Whereas the cognitive model is structural. It is trying to figure out, well, what are the different parts, what's the topography of the client's life and what's in front of the person. So another way of kind of looking at it is you have the same dichotomy in biology, in looking at how organs function or what organs are made out of. Now, both are important, and you will see gains in either. That's 100% true. Like I said, the cognitive behavior therapy is also effective. You don't get nothing out of it. And so it is two different ways of looking at a problem, fundamentally. And just in more graph form, these graphs are kind of representing, I thought this one was really good as far as CBT is concerned, looking at how the events triggered the schemas, and that shoots right up into the relationships between behaviors, emotions, and thoughts. Looking at things this way, in this sort of structural way, what you're looking at is how the same schema is popping up in the different problems in a person's life, and ultimately you are addressing those issues, and it doesn't really matter where you start. You can start with thoughts, you can start with emotions, you can start with behaviors, and as long as you're working your way back to the schemas, you're good to go. It's a structural approach to therapy. Whereas with behavioral activation over here, well, what you're trying to do is you're trying to shift someone from one cycle of depression where they're feeling low, they're getting less out of life, and your only target is what they are physically doing and changing only that. And that will make them feel better, and they'll get them more in their life. It's very limited in what you're addressing. So I thought it was kind of worth pointing out, when looking at cognitive behavior therapy, there are contrary findings to, well, why does cognitive therapy work the way it does? Some researchers have found out that when they've done their own studies of isolating the different aspects of cognitive behavior therapy, it actually, in some studies, shows that the actual cognitive interventions are not related to outcomes at all. And what really is related to the outcomes are the skills of the agenda setting. The first 10 minutes of therapy, when you're setting the agenda, might actually have the larger effect in therapy than everything else you do in the next hour.
Wait, but how could you study such a thing in a research project? In other words, we're only giving the first 10 minutes.
Yeah, they do.
We killed the last 50.
They do deconstruction studies, yeah, where they're only doing agenda setting, and they would have some sort of way of limiting therapy to only that. Yep, yep. We also see in general that, well, in non-cognitive therapies, people's cognitions change. So it actually becomes, a question of, is the cognitive change that's achieved, was that a consequence of the therapeutic improvement, or was that what caused the improvement? That's not obvious. It might just be an outcome. As we're going to see with this particular research, the cognitive changes of the people that had only behavioral activation were quite large, and they weren't addressing thoughts one bit. So it could very well be that cognitive change is really a result and not a mechanism of change. Could be. It could also be that, all these different aspects of a person, their thoughts, emotions, and behaviors might actually just line up, almost like parallel lines in their life. And so it might not matter where you start. You could start behaviorally, and that will bleed into the way they think and feel. You could start emotionally, and that'll bleed into the way they behave and think. That might also be. So it's just worth kind of putting on the table. It's not exactly clear that cognitive behavior therapy, what makes it work is the cognitive aspect of things. It's not clear, but could be also. I don't want to misrepresent. There's also loads of research that does support that hypothesis, but it's only a hypothesis. So as far as our 2006 paper is concerned, what do we got? So we had 241 participants. They were between 18 and 60 years old. All of them met criteria for major depression, which they were either scoring 20 or higher on Beck's assessment, or they were getting a 14 or higher on the Hamilton scale. And we were excluding everybody who had a personality disorder. So we were only dealing with people with major depression. Everybody was assigned to one of 4 groups. You were either getting behavioral activation, cognitive therapy, and the third group was broken into 2 subgroups. You were getting medication, or you were getting a placebo.
How can you give placebo therapy? Like you were getting medication?
You go into a psychiatrist, and you're being given.
There was no therapy.
No therapy. It's just meds. And what they did was they didn't want to just see what worked best, but they were also curious, maybe these therapies will act and behave differently with different levels of depression. So they stratified more severe depression and less severe depression to see how do these 3 measure up. And like I said, all these therapists were well trained. They were receiving supervision from the best in the field for their particular therapeutic tradition. And this is a breakup of how everybody was put into their various groups. Unfortunately, there was 1 suicide in this particular experiment, and it was in the medication group that we had the suicide.
30 did not complete in the antidepressant group?
Yeah.
That's pretty high.
Yeah. Yeah. This is yeah. You see a lot of, with especially medication, high rates of non-completion. The non-completion rates between behavioral activation, cognitive therapy are not statistically significant, and they're low. Lower scores.
Again, you also
Yeah.
medication but no therapy.
Yep, medication, no therapy.
Just meds.
Just meds.
That's what I was.
Just meds.
And one was placebo and one was not.
And one was not. Okay. So we've kind of already gone through
But
this.
the placebo
Yeah.
effect.
We don't have their outcomes yet. No, these are just how people are broken up.
The do not complete was not assigned, maybe because they did not experience.
Yeah, exactly. They weren't experiencing side effects. That's why they were completing it. 100%. Okay. So and again, like that, and it's just worth seeing. Like, if you're making a clinical judgment, like, maybe it's not a good idea to put someone on meds. Like, that might not be a good idea. You got to watch out, because they might come off meds and you just earned yourself a whole month of mess with how their biology is now fluctuating dramatically.
Or they could be suicidal from the meds themselves.
Yep, that sometimes happens. That sometimes happens. So again, we basically already went.
And sometimes it can save their life.
Yep. So I don't know. That issue is something to think about. Marshall Linehan.
Save their life, not necessarily,
No, I
but
know.
just
And,
like their life becomes brighter,
Right.
brighter. That whatever was bothering.
And that could be the right, and placebo's powerful. Like, I don't want to poo-poo it, but we do as clinicians. We're not just making decisions based on what's clinically good, but we're also making decisions based on what doesn't get us fined or thrown in jail. Like, that also is true. So Marsha Linehan, in her research with borderline personality disorder, she puts down on the table point blank, there's zero research showing if you put that person in inpatient treatment that it helps them.
Right.
And in fact, there's mountains of research showing it hurts them and makes them way worse, and you're more likely to have them commit suicide when they're released from hospital. But we do it so we don't get sued or have malpractice.
What about psychiatric boarding schools?
I'm only talking about borderline personality, self-harm borderline personality.
I'm talking about borderline personality. I just wanted to know if there was any research on psychiatric boarding schools. Or,
No idea.
maybe
I don't know. With their boarding schools, they're more like live-in, long-term.
Yeah.
They can actually be very helpful. I'm just talking about brief hospitalization,
Oh,
so the
brief
person doesn't
hospitalization.
so the person doesn't kill themselves, in theory.
Yeah.
Okay.
That was a question.
Fine. Okay. And as far as what was being added was the exploration of alternative behaviors, role playing, and validation were the three new ingredients in the behavioral aspect that didn't exist in the first research. And again, the main emphasis here of CBTs, we're targeting cognitive beliefs. We're trying to figure out which ones are generating erroneous interpretations of events, and that's what we're shooting for here. And we're hitting first automatic thoughts, and developing treatment into trying to look at schemas, core beliefs later on in treatment. So, what do we got for the pharmos? That's right. The medication they were using was paroxetine. They were on a flexible schedule. They were trying to work.
Paroxetine is what?
It's an antidepressant. So the psychiatrist was encouraged to be a nice psychiatrist when he was meeting with the clients, and it's no joke. Wampol's lab did a really cool study where what they set up was having the good psychiatrist giving the placebo, and he was putting in a lot of care and describing everything, good bedside manner, and the bad psychiatrist who just gave the guy the actual medication. And it turned out that the good psychiatrist who was giving the placebo had better outcomes than the bad psychiatrist giving the real medication. Placebo effect, right.
So the medication, what really makes the medication effective?
Yeah.
That is always the question.
That is the question.
Or what's really triggering depression, which is reflect that if someone who's being nasty or critical or judgmental could be a very big trigger if you have an awful psychiatrist. That could send you back quick.
Yeah.
Because you're going for help and you're depressed and someone's keeping you in that.
That's 100%. It's just worth noting, as far as when we start looking at the outcomes, that a large part of this is going to be not just the actual medication. As far as the measure is concerned, everyone was sorted out using the SKIDs to make sure we were only treating people with major depression. We were using two measures for depression, Beck's scale for depression and the Hamilton. And what's really cool to keep in mind as we go through this is the way that Beck conceptualizes depression is a lot more cognitive. So if you're using that assessment, a lot of the questions have more of a cognitive bent to it than the Hamilton. And we're going to see that there are dramatic differences in how the outcomes are measured in these three groups.
What's SCID 1 and SCID 2?
SKIDs. That's structured clinical interview for the DSM.
Okay.
Yep. Yeah, of course. And everybody's being monitored. Everybody is being monitored by master therapists to make sure they're actually doing CBT. No one's slipping in anything. Everyone's actually doing behavioral activation. And that was also measured using cognitive therapy scale that Young developed. And unfortunately, there was no actual scale to use to make sure people are using behavioral activation, because this was before it was invented. This is the birth of behavioral activation. So they were kind of doing a best guess on that one. So these are the outcomes. What do we got? So when it came to we saw that the pharma solution, we had high rates of attrition. People are dropping out like flies. It was 44%. Whereas when it came to cognitive therapy and behavioral activation, it was over 13%, 16%. And like I said, they're not statistically different. That's pretty low
In terms of dropout.
in terms of dropout, right? When looking at the high severity depression group, behavioral activation was way more effective than cognitive therapy. It was way better than the medical option with the psychiatrists. And what was also really cool to see was how that behavioral activation, the response rate was significant, as well as actually seeing that they're not only were people becoming clinically not depressed, but even those that weren't, we were seeing that something was happening with behavioral activation. You were seeing movement with it, whereas with the cognitive therapy and the medication, you weren't seeing much response in those two. As far as the less severely depressed group, things are pretty similar, actually. The results are basically dead even. Medication, cognitive therapy, and behavioral activation more or less are doing the same thing.
But the more severe the BA
Worked way better. So we go to the next slide. We'll see as far as the graphs are concerned. The one on top is Beck's assessment, and you see the solid line is behavioral activation. And over 16 weeks, this is what that treatment looked like. Whereas with cognitive therapy, it's running in third, and behavioral activation is just outdoing the medication. With the Hamilton, the scores are more tight, but it's the same pattern. And again, the reason why they're more tight is because this scale is not actually factoring in depressed cognitions. Yeah. And the low severity group on the right, you see it's basically the same scores, but still we have behavioral activation outperforming cognitive therapy.
Behavioral activation and medication, will you have a better outcome?
Maybe.
Based on this?
Maybe. The Barlow has done a lot of work on that. What ends up happening is like you have a short-term boost, but by the end of treatment there's no difference. So it's like it might, like the heartache of going through the medication ultimately doesn't pay off at the end of treatment. You might long-term research shows you don't even get that. What you get is a quick boost. So like if you need to see some action quick in therapy, yeah, it's a great strategy. But seeing long-term outcomes using medication plus therapy,
But you see on the top graph, the medication, it looks like if you were to continue, it would actually succeed more than the solid line.
Good question.
a little
You
bit.
see that
Yeah, a little bit.
Right, that's why I was wondering
Little
if you go
bit.
together.
Little bit.
So
Little
it
bit.
looks
Yeah.
like that
Little
the
bit.
medication will win at the end.
Yeah. And that's also not even statistically significant. So it could have easily been the reverse. So like it's really not. Yeah, you're right,
We're
but
talking about what,
yeah.
16 months or 16
Weeks.
weeks?
16 weeks.
So meaning if you were to take it over 10 years,
Mhm.
maybe it would be significant.
Oh, you don't want to.
No. I mean, you're ending up. Yeah, it's. Yeah, you no. You get way more problems over long-term medical use by a lot. Yeah.
So now this thing has been around since 2006, right? Have
Yep.
they tried it for schizophrenia? Have they tried it for borderline? Like, where has it been tried, or is it still sticking around depression and anxiety?
A lot of DBT is based on behavioral activation. A lot of the same skills are going to be lining up. High validation, opposite action.
Sounds very
You're
similar.
trying to stay away from avoidance. And as far I haven't seen anything with behavioral activation alone being used for schizophrenia, but
Not alone.
ACT sure is. And ACT is basically a souped up behavioral activation.
Yeah.
You're just adding in values and a lot of metaphors.
Yeah.
So, and that is very successful with schizophrenia. Yeah, so here we have, so we're breaking up here, what we're looking at is in the black is where you're having full remission, you're seeing full recovery, and the light gray is, yes, you're seeing a response. So when you're looking at the Beck's assessment, you have a high response rate with behavioral activation. Whereas that's kind of shrunk with the Hamilton. So I thought that was actually very interesting to see that slight difference. But here again, this is what we're looking at in terms of the outcomes. Okay.
Wait, can you go back to that other one and explain it a little more?
Yeah.
I don't get what the gray is. and I don't
Yeah,
get
so
what
the gray is that you're seeing improvement, but the person still is clinically depressed.
Okay.
But that's how many people are seeing improvement. So I mean, it's not so much. I mean, like here's like a 7% difference and 8% difference. It's not so large. But when it came to behavioral activation, it was quite large.
So ideally, if these people would continue with behavioral activation thing past the 16 weeks,
Yeah.
they would be doing a hell of a lot.
Yeah, they would be fully recovering. Yep. But according to how Beck defines depression, because you don't have that with the Hamilton, which is on the right. It's the same group of people, but how you define depression is super important.
So,
Yeah. Definitions are everything. Right.
Success.
Right. How you define success. Right. Does it include cognitive aspects or not? 100%. Okay. So a couple discussion points here. I mean, like what's coming out here is that this study was a major challenge to treatment guidelines. That we're seeing that behavioral activation is way more effective at treating severe depression than medication. So that has been a shift with treatment recommendations. That behavioral activation is considered the gold standard for depression. What's kind of interesting about this also is a little question of this idea of, well, what keeps people from becoming depressed? A lot of times when we look at this sort of research, we're thinking, well, we're looking at populations which for whatever reason they got depression, but most people don't. Like very, very few people end up, when something bad happens to them, actually developing depression. I mean, it is high, if you're looking at it's 1 out of it is high, depending on some research, it's 15 to 20% of the population in their lifetime. But at the same time,
And then there's the people who don't.
loads of bad things happen to people. Like even those people who end up developing depression.
They might just be drinking. You can't really. That doesn't really mean anything, because people do all sorts of things that.
To handle what they don't want to handle.
Yeah, and they may be a lot of avoidance, which isn't really.
It's worth looking at the research of Meichenbach on this one. That what he's coming out show, what his work is really trying to show, why it is that so many people don't end up suffering psychological problems when really bad things happen. It's not so simple, it's not automatic. Although it's true, yes, it is very high. But again, it's
not always when bad things happen that depression comes
I have a
out.
question, just like, it's not interesting, sorry.
Yeah.
It's a case kind of thing of like somebody who, I mean, and I've seen this kind of thing before, when someone's quite, maybe there's a depression somewhere, but they're keeping themselves moving from one thing to another thing almost compulsively.
Yeah.
But they keep themselves motivated because they don't want to go down.
Yeah.
Is that healthy or is that unhealthy? Like in this
I don't know, right?
understand what I'm saying?
I mean, if you're a cognitivist, that would depend. If your focus is on what they think, then it could be.
They know that it's
Or it could.
But they're also keeping themselves moving so that they don't get. I don't know.
Your treatment theory matters. Yes or no. And it's a cool question. We're kind of touching on it a little bit. Is when someone comes in the room, one reason why to have a pretty broad scope of approaches is because not everything works for everybody. But at the same time, you are confronted with this individual I'm looking at right now. I could either be a cognitivist, I could be behavioralist, I could go with ACT, I could do a lot of stuff, and it really matters. It really matters. It's not obvious, if I were to take a behavioral perspective on that client you're talking about, that, well, those aren't problems, and I would treat them like they're not problems, and he would buy into the philosophy of treatment, and he'll maybe, it's likely he also will consider them not a problem, and he'll leave therapy feeling great. Things worked out. But taking a cognitive approach, it might work, it might not. I mean, you get that both ways, but it's you're really making a choice here. How you want to name the problem, not entirely, but in a pretty big extent, makes the problem.
That's a big statement.
Yes, it is. So as far as Meichenbach's research illustrating how, it seems to be one of the main reasons why most people don't get depression is because they're living a behavioralist life. They have friends, they have family, they have fun, like they're doing things, right? And
that can be very constructive,
It-
but like that,
yeah.
like say there's like being like a terrible history.
Yep.
And an abusive history, whatever, back in the background.
Mm-hmm.
Right, it
That's what
can
I'm
flare
saying,
up.
like, and then it can flare up, right, so.
Yeah.
think
I only mention it because it really does goes against the grain of therapeutic thinking that most people who go through horrible things in life.
That's actually, the research doesn't show that. No, people
Yes,
going through
it's
things do not necessarily.
there was a whole scandal with
the
the APA on this one. There was a whole scandal with the APA on this issue. That while it's not what you'd think. It's something like 70% of people. Like it's a small proportion of people, but it's worth at least like thinking about as a.
Well, that's what Dr.
Yeah.
Malilaha did. He went all over the world.
Yeah.
And he found this thing, basic pH, that these are the basic 6 coping mechanisms that everybody in the world manages to get through the worst things in humankind. And he teaches them as prevention, actually. And they're going around the kindergartens and they're teaching coping skills to 3-year-olds
because they
in this country because it really works. They go through earthquakes, they go through terrorism, they go through the worst abuse that ever was, and they're okay because they have their coping mechanisms.
But they've also found,
pH sometimes.
They've
Basic
also,
pH is great.
They've also found that these major events, people actually have more coping skills. It's the things that happen on the day-to-day that break people down more. That if you
He's
look
talking
at
about everything. He's talking about these people are basically okay if they're able to hold on to the basic pH.
But if you look at big events that we think will knock people out, they're not usually. It's usually the things that are consistently happening on a day-to-day basis that are wear people down, rather than that big event.
Right.
That big event we are actually programmed often to deal with well, but it's the consistency is what wears us down.
I saw one paper
And often because you have a community of people there helping you get through this.
I saw one paper with after real life-threatening tragedies, they go in, they do debriefing. It's oftentimes recommended. A lot of research shows it actually makes it worse in the debriefing.
Totally.
Yeah. So it's like pick your poison. Like that's basically like the thought I guess I'm sharing is that. Maybe kind of thank God that people usually do pretty well. I guess that's more of like, kind of putting that one out there, and that it might not be that the complex sort of going deep in, the cognitive distortions, it might actually be more likely, if you're a betting man, to just kind of be a normal dude helping people do a normal life. Like that, and I mean like that might actually be it. Not always. And definitely there are a lot of problems that are definitely not that way when you get into personality disorders. But DBT definitely challenges that notion 110%. And maybe you don't have to go so deep. Maybe it's enough to throw a bunch of skills at people and they end up not wanting to kill themselves and get a job. And then they end up feeling pretty good. So it's something to think about. It's something to think about.
I think what I was talking about, just always think of the Gottman thing, when you talk about couples and the ratio of good interactions, it's 5-to-1, and I think that life is like that too. Having many more negative interactions with life, they tend to not be resilient. Their resilience breaks down.
100%.
Which I think is what we do in therapy, actually. Hopefully we can provide a secure base for people that come in that are broken and rebuild that secure base, inherent there.
100%. It also even when you are going to get cognitive, the research coming out of this sort of branch is wondering, well, maybe Albert Ellis kind of had it right in his version of cognitive restructuring. Beck, like I said, he's a poet. When you see that man in action, it's beautiful to watch him. Has anyone seen Albert Ellis work? The man's a jerk. He's mean.
Obnoxious.
He's obnoxious.
I remember
He's
now.
like, why are you
horrible?
Very in your face, yes.
And that is the type of cognitive work that's done in DBT is only Albert Ellis's approach, not Beck. You tell him to do it, and even with the in DBT the different sort of irreverent responses you give a client is like you kind of actually put it in their face a little bit. You are a little irreverent. You are kind of like, hey man, just think different. And that might be a strategy worth exploring. Especially something as severe as borderline personality disorder. So that's I guess the long and short of behavioral activation. And like I said, like if you guys are interested, I think it'd be really awesome. It's an awesome book to get, the one that I cited here, the 2010 book. I have it. I can loan it out, but it's cool. It's a cool approach to take. One thing I was like kind of thinking about, trying to figure out, well, why is it that this is more effective with depression? And I don't know. There's a lot of research. It's kind of funny, how it's not a lot, but it's a fair amount. That the more that the older the therapist, the less effective he becomes. It's very interesting. The more you work as a therapist, the less effective you become. So one thought of it, one possible explanation is, well, it might be that, well, you're being responsible, you're trying to do the right thing, you're learning a lot of different interventions, things get very complex. And it might be that one reason that manifests is that maybe the therapist making things a little too complicated, and they're tripping over their own tennis shoelaces. And something as simple as, maybe one big factor here with behavioral activation is the fact that it's extremely simple.
It's very nice.
Not so many moving parts. That might be another aspect to this.
Yeah.
Do easy therapy. See what happens first. Someone comes in, make sure they're eating breakfast and they're sleeping 8 hours, then see what happens. It might be the end of treatment. I've had clients that way. Good. You're eating hours and sleeping. All of a sudden, your anxiety and depression scores are basically nothing. Have a nice day. That could be.
Thank you very much,
Thank
Yonasan.
you.
That was very interesting.
Yeah, thank you.
And practical and hopefully educational.
But
and
very
reinforcing.
simple, not too complicated.
There you go.
Keeping simple.
Don't get
Very
Keep
good.
it simple.
Very good. Yes. Being simple. Because it actually does work.